radial tuberosity of the bicep, and this is where I think there's a lot of individuals out there that consider this a very, very difficult surgical intervention to recover from if you're a throwing athlete. And a lot of times that's due to previous injuries, but then also how that rehab process is kind of formulated. And we're gonna, in future episodes here, we're gonna take a look at how we can bang the myth of staying away from kind of a little resisted flexion and supination, how we're supposed to stay away from this loading of extension, of abduction and external rotation of the scapula, because it loads up that biceps tendon. Good, fine, and okay, but we need to think better than that, because when we do that for 4 to 6 weeks, we're missing out on a huge pivotal kind of time frame in that individual's healing process, and in which collagen tissue is very ripened to be laid down to those surgical interventions. With regards to the function of the biceps, we're taught anatomically from a cadaver that the biceps, it flexes the elbow, it flexes the shoulder, it adducts or horizontally adducts the shoulder joint, it internally rotates it, it supinates the forearm. But from a functional perspective, the biceps, the long head and the short head of the biceps is loaded with posterior tilt of the scapula. It's loaded with that posterior tilt and that external rotation and kind of that downward rotation. It's loaded with extension of the shoulder and that external rotation of the shoulder. It's loaded with that external or that extension of the elbow and that the pronation kind of the forearm complex, and a combination of those as the scapula and the thoracic spine load to further load the shoulder joint itself. So with regards to anatomy, we need to take a step back and remember that cool little butterfly right there. We need to take a step back and look take a look at how the protocols that we've medically been given have been a very isolated like phenomenon that are not taking advantage of the three-dimensional qualities of the body and not taking a look at the root of the problem. Although yes, the bicep was injured, we'll get in there with our gua sha, re-instigate kind of the inflammatory process, scratch up some of that stuff. Coincidentally enough, have over the years had some a significant amount of, or at times, some false positives with regards to impingement syndrome and a potential slap tear, just due to the subacromial arch, the tendinopathy buildup of tissue of that long head of the biceps, and the supraspinatus tendon just really packing up that area in there and creating a crap ton of irritation to that tendon. And we need to also realize that there's a big chronic-like element that's built into this, in that this failed tissue healing that has occurred, whether you or someone you know subconsciously or consciously realize it or not, is a big contributing factor to this as we develop into the further states of tendinopathy, in which we get to that degenerative state or disrepair state. There's a significant amount, or can be, inhibition of nerve-like effect to that tendon, as well as blood supply. With it being tendon, we don't get as much blood supply to that area, and we don't get as much nerve intervention. So episode 2, episode 3, episode 4, we'll see how many episodes it takes for us to get this stuff down. The long head of the bicep, the slap tear, superior labrum, anterior, posterior, which means the top of the labrum, anterior to posterior, front to back, we get this tear. We talked about a grade 1, 2, 3, and a 4 tear. A grade 2, we forgot to classify that there could be a potential anterior lesion, a possible posterior lesion, and a possibility of kind of both of those within the labrum. We talked a little functional anatomy, which we're going to dig into a little bit more gnarlier when we have the ability, or when I have the ability, to get my hands on an individual and show you what we would do to constantly assess and reassess using our FMR to the affected side and using the healthy side to drive motion, aka collagen reproduction and healing, to the surgically innervated side. I think you guys are going to find this super, super interesting, a little bit complex. Hang with us on this. A great way with regards to rehabbing the shoulder. We're going to look at rotator cuff repairs, kind of comparatively speaking as well. Remember, 17 muscles are anchored to the old scapula right here. Head of the humerus 4 times the side of the glenoid fossa. The labrum creates a surface that creates a depth twice the depth as what would normally have access to without the labrum. 75% greater diameter up and down, 35 to 40% or 45% kind of in the transverse plane, greater depth for us to approximate, load sequentially this mushing-like effect of these chain reaction-like qualities that are driven from the thoracic spine, scapulothoracic joint, as well as the hips. Hang in there, guys. I love this stuff. Let's get nerdy.